We've got about 45 minutes that I'm going to spend talking to you. Who here has already started our program and is kind of on their way on their weight loss path with us? And who here is kind of thinking about it, trying to learn more about it, checking our program out, doing a little bit of shopping? Okay, good. It's about half and half. Great. Well, my goal today in the next 45 minutes is for you to understand a little bit better about bariatric surgery, to kind of fill in some of those gaps that are probably there, and more importantly, tell you how we do it here and what makes our program different than other programs. And so I'll start with that. So my name is Dr. Greg Mancini. I'm one of the bariatric surgeons here, and we're going to spend some time doing that. So we will review the program of kind of the ins and outs of that. A lot of you who have already in our program already know our team, and so I'll let you know who they are. We're going to talk about the process. Everybody wants to know, well, how do I get from here to surgery? We'll talk about that. I'll explain the surgical procedures. I actually have some animations that I'll kind of walk you through today. A lot of people have questions about the surgeries. Probably the number one question I get is, well, which surgery should I get? And so we'll kind of talk a little about the selection for that. And then we'll move on. And it's important that you walk away today knowing what your BMI is, which is called body mass index. I'll talk a little bit about that so we are up to date on kind of our definitions for things. And then if it seems like this is the place where you want to work your pathway for weight loss, then we can help you with that. So I'm Dr. Greg Mancini. I get to be on the top of the list, not because I'm giving the talk today, but I'm the medical director. I started the program here 10 years ago. You probably recognize the second name on the list, Dr. Matthew Mancini. We are relation. He is my older brother. What's really interesting is try teaching your older brother something, right? So I actually trained him in bariatric surgery. So that kind of tells you how a good relationship that we have. We've been working together as partners for the last 10 years, and we started the program. Our program has done well. We have very good results, and it's allowed us to grow and provide more care for more people. And so we added Dr. Beasley and Dr. Cassane, so two female bariatric surgeons. There's nobody in the state that has two female bariatric surgeons, and we know that 8 out of 10 people that actually seek out bariatric surgery are females. It's not because they're the only ones that need bariatric surgery, but our males are really reticent to come in. And we would love to help more men with their weight loss than we currently are. We also, if you've been in the clinic already, you've met some of our physician extenders, either Lynn Castle, Sarah Campbell, Sonia McWilliams, and Tessa is our dietitian. The majority of this team has been put together and been here for 10 years. So we have a lot of culture that we've developed over that time, and hopefully you feel it. Our goal is for you to feel what our culture is like. And there's one main theme that you'll feel to that, and that's education. Welcome to UT. Many of you have been here before. Maybe you haven't been here before. I've been here 15 years, 5 in training and 10 in practice and as a faculty member here at the university. And it's really changed in the last 15 years that I've been here. A lot like Knoxville has changed. This is a beautiful hospital. It's always had great physicians, and the patients have always had good care. But we've really done a lot in our facilities, and I think you guys can kind of see facilities now match the quality of care that we give. And we're really happy to have a nice hospital. Everybody likes billboards and puts billboards up. UT has done very well across the metrics, and we are considered one of the best hospitals. We're number 2 in the state, just behind Vanderbilt. What's important to you to know when you start your thinking about bariatric surgery is where to have it. And there's a group of an organization that has certified bariatric centers, and that means you aren't just say you're good, but you prove you're good. And you prove you're good by sharing your data and your results with this organization. That organization is called MBSAQIP, MBSAQIP. That stands for Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. We've been certified 3 times by this organization. Every 3 years you have to undergo a survey. That means you have a surgeon, a bariatric surgeon actually comes to your hospital. You sit down and review all of your cases. You look at all your data. We walk around the hospital making sure the facilities are there. They meet with the leadership and make sure that it's a place where things are going to be done well. And we've done that 3 times and have been successful each time. I would suggest if you are serious about bariatric surgery that you have bariatric surgery done at a certified center. And thankfully in Knoxville, there are 3 centers that are certified. We're one of them. So we talked about this word, BMI. It's actually an acronym. It stands for Body Mass Index. And that's sometimes doesn't make very much sense to folks, but as I explain it, hopefully make more sense to you. So we use BMI as a marker of whether you should have weight loss surgery, okay? And you ask yourself, well, why don't we just use weight? Well, weight alone is not a very good marker of whether you're unhealthy or not, right? Because you can have Shaquille O'Neal, who's 7 feet tall and weighed 350 pounds, and he's at a reasonably healthy weight. take him and shrink him down to 5'5" and make him 5'5" and 350 pounds. And I think a lot of us understand that that's not a healthy weight. So unfortunately, our height is one of our biggest predictors. And I don't see anybody here who is going to grow any taller. So in reality, we are talking about weight, but it's the relationship between our height and our weight. So since we're not going to get taller, we have to reduce our weight to really move the BMI number. And we use BMI because it is the best predictor of who's going to die early. You know how that's been figured out? Not by medical doctors, but by insurance companies. Okay? Surprise. Do you know insurance companies how they lose money? They don't lose money. And what they when you get a life insurance policy, you know how they figure it out? How much you're going to pay in your premium? Is they figure out when you're going to die and they charge you more than they're going to pay out. Right? That's the only way that can work. Okay? So what they know is that BMI is the #1 predictor of early death. Okay? So at the end of the day, what we're talking about here is making people healthier with BMIs so that they can live longer. So I'm going to show you some images here of what we talk about, how these BMIs correlate. A normal BMI is between 18 and 25. People look at that silhouette and say, well, that person's skinny, right? Well, that's considered a normal BMI. About 1/3 of the U.S. population fits into this category. The next category is considered overweight. It's a BMI of 25 to 30. 1/3 of the U.S. population fits in this category. I fit in this category. I have a BMI of 26. People look at that silhouette and say, that person looks skinny, right? Well, that's actually considered overweight. The next 3 categories fall into the obese categories. BMI of 30 to 35 is considered obese. People look at that silhouette and what do they say? It's normal.
Husky.
Normal, right? Well, normal is probably not the right word. Average, typical, right? And that's kind of, I'll show you where the numbers work out for that. The next category is what we call severe obesity or surgical obesity, because at this BMI is where we start talking about whether surgery is helpful, and that's between 35 and 40. And a lot of people will look at that person's silhouette and say, well, they're overweight. But this is actually where our own image of ourselves has really changed over a couple decades. And morbid obesity is a BMI over 40. And anything with the word morbid associated with it is not good, okay? And morbid means early death. And the sad part is that we actually have super morbid obesity, which is BMI over 50. And it's very important that we kind of understand where we fit in this to figure out how important it is to do this process. Okay, so hopefully all of you know your BMI, or we can figure that out for you today. So let's look a little bit about how we're doing in the United States. Okay, I have 3 pictures up here. The U.S. in 1990, the U.S. in 2000, and the U.S. in 2010. Now you notice there's different colors on there, right? It's not because we ran out of ink. It's because each of those colors represents what percentage of the population is in the obese category. Like in 1990, I was in high school in 1990, okay? And you can see here that most of this country was in this 10 to 15% of the population being obese, okay? You had a couple states like Colorado and Nevada that didn't have any data. You had some western states typically have about 10% of the population. So that's 1 in 10 adults, right? 1 in 10 adults obese. And you look at what would happen in 2000 and 2010. We added 2 more categories, 25 to 29 and over 30%. Well, in 1990, we were talking about 1 in 10 adults. In 2010, which is 20 years, we're talking about going from 1 in 10 to 1 in 3. If our bank accounts looked like our weight, we would be very rich. So this is a little infographic kind of telling you that we're not alone in this. This is really a social and societal problem. Look year after year, 2006, 2008, 2010. You notice the Southeast is the heaviest part of the country. Okay, if you look at high school graduation rates, if you look at early death rates, if you look at diabetes rates, it's all here in the South. We have struggled since Reconstruction. And so in these states is where our largest obesity issues happen. And we live right here, right in the middle of it. So why do we have this obesity epidemic? Everybody asks, what happened in 1990? You know? And the question is well, why? Well, the reality is that biology is against us. You and I are genetically designed to do one thing, survive famines. None of us would be here if the previous generations didn't survive on very, very poor quality and very, very sporadic food sources. We spent most of our human existence without a food supply. It really wasn't about World War I and World War II that we developed massive infrastructure to have farms that were big and we could do this large production of food, wheat, grain, all those things. Before that time period, it was very sporadic. okay? So we can live 21 days without a single calorie put into our body, whereas we can only live 3 days on water. Okay, water is more important than anything. So the reality is that our food availability means that we are always in the storing form and never in the burning form. Okay, when we talk about hunger, talk about being hangry, you see the Snickers commercials, we miss lunch and boy, we're just really irritated, right? That's not hunger, right? That's not hunger on the world starvation kind of scale, right? Okay, missing a couple of meals, going a day or two without food, now that's probably where you really begin to experience hunger. The other thing about food is that we're driven to eat, okay? We wouldn't have eaten all the really lousy things that were around us, right? People watch these shows where people go out and they're out in the wild and they eat what you find, right? We spent a lot of our human existence living that way. And how hungry do you have to be to eat, insects or food that may be near spoiling, right? You have to be pretty darn hungry, right? So the reality is that we are very driven to eat. It's one of our primal drivers that we have, maybe just below breathing, okay? That's how strong our drive is, okay? And so when we eat food, the drive is finally quieted, right? We say, I'm full, right? Well, what happens in about 2 hours? Food moves out of the stomach, and we start to get those little rumblings in our stomach, right? And then the drumbeat in our brain about being hungry begins. And then our search begins for our next food, right? Whether it's that little Hershey's Candy Kiss that's there, or the soda machine, or the potato chip bag, it just never goes away. These cravings never go away. Even with bariatric surgery, they don't always go away. And this is why diets don't work, because we starve ourselves for 3 or 6 weeks, we lose weight, and then we have this huge weight gain as we yo-yo back and forth between being full and starving. And often our patients come to us to say, I've lost 100 pounds 3 times in my life. I can lose weight, I just can't keep it off. It's a really common thing that folks tell us. So, and then the other thing is that we have created a society where we don't spend very much energy getting our food. So if you think about your mother or your grandmother, okay, and think about how much energy she expended providing the food that we ate, okay? Think about, in traditional times, how much effort it took for a person to go earn the money that they made to go feed themselves, okay? Actually, until right about 1900, okay, any time before that, we were just like every other mammal on the planet. And that is that we spend about 3/4 of every meal finding our next meal, right? You see the cheetah on the TV show? That cheetah better make that kill, because he just spent 3/4 of his calories getting his next meal. If he doesn't get it, boy, he has even less energy to go get it next time, right? So we were just like that. We would spend about 70% of our calories making or earning the money or making the food to do that. How much calories do we burn when we roll up to Chick-fil-A? We put it in park, right? That's about all we do, right? So we really don't expend any calories earning or making our food, right? Most of us don't live doing labor jobs. A lot of us have sitting jobs. So we really don't expend any energy. And then the food we eat, it is really good tasting, right? It's really good tasting. And then the other thing is that Madison Avenue is not on your side. It doesn't care that you're healthy. It cares that you buy things. This is a great chart showing how our portion sizes have changed. Our portion sizes are a really big reason why our portion sizes have changed, right? And that is, as we look at the original Burger King hamburger, this is the single that comes in the kids' meal. Okay, we look at the small fry they don't do anymore. This is a regular fry. It's not even a large fry. And look at the vending machines with our sodas, okay? Now you can rarely get a 16-ounce can or 16-ounce bottle. They want you to buy a 20-ounce bottle. And we say to ourselves, look, it's more for less. It's more for less. Look, it's more for less. 35% more. You know, same price. Isn't that great? Well, it may be great to the wallets, but it's really not great for our waistlines, because we never drink a little bit of this and put it away for later. I don't. It's not our biology, right? So Madison Avenue is not on your side. Biology is not on your side. So the reality is that we talk about genetics and our body loads the gun, and then our environment pulls the trigger, and yes, obesity is killing us. And that's why we are doing something about it. So the impact of obesity is on every aspect of a person's life, right? We talked about early death. We're going to talk a little bit about other medical problems that are completely driven by obesity. We know that disability is highly associated with our weight. People that are obese have higher medical costs compared to people of normal weight, and quality of life issues. So we know that it impacts a person's life on every aspect of it. And in Tennessee, we are somewhere between 4 and 8 is the top heaviest state in the country. And a lot of our kids that are heavy are not growing up and growing out of our obesity that we have. So it's really an issue that I'm not going to solve, you're not going to solve individually, but as we work on this, we can solve this together. So I talked about before some of the medical diseases that are directly related to weight. And it's really interesting because doing this for 10 years, when I put this slide up 10 years ago and talked about, well, their diabetes is caused by their obesity, people said, no, it's not. And said, well, the high cholesterol, it's related to your weight. You realize that, right? And they said, well, no, it's not. I just have high cholesterol. My mom had high cholesterol. And they said, well, is your mom heavy too? Yeah, okay. What about high blood pressure? What about fatty liver disease? What about our sleep apnea? What about our reflux? These are really highly related to our weight. And the reality is these are automatic controls in our body that the weight, that the actual fatty tissue changes our hormones in our body, not just the hormones of whether we're man or woman, but in our hormones that help us regulate how our sugars are run. Okay? So imagine at your house if the thermostat's broken and the heat's on all the time, right? We have a broken thermostat, right? So as we describe it, is obesity breaks the normal thermostat in your house to regulate your sugars. So if we fix your obesity, for many patients, I'll show you a graph on this, they get a better way to regulate their sugars. One of the most common reasons folks come to see us is that I don't want to have this diabetes anymore and this weight. So a lot of these medical diseases actually improve when we lose weight because the body gets a chance to do its normal balancing. This is newer information, is how are cancers related to our weight that we carry? Okay? Well, if you notice, almost all of these cancers are hormonal-related cancers, right? Breast cancer, ovarian cancer, not just the women. How about prostate cancer? These are tumors that are actually driven by estrogen, right? And we know that the fatty tissue that we have, whether we're a man or a woman, makes more estrogen. So when we reduce somebody's weight, the amount of fatty tissue that they have, we actually reduce people's risks of breast cancer. We have a high referral here from our gynecology oncologists who do ovarian cancer because they'll do the ovarian cancer surgery and they don't want the ovarian cancer to come back, and so they want them to come have surgery so that their weight goes down and so their risk of cancer coming back is lower. Okay? This is probably newer to you than other things than this information here. So why not diets, exercise? Why not medicines? Well, the reality is the answer is a multiple choice. It's E, all the above. You are going to be doing exercises. You are going to be doing a diet. We are going to be talking about what medicines can help you. And where does surgery fit into that? And that's what we'll talk about. We have more medications on the market than we've had before. And I'll show you a couple. And the one that's been around the longest is phentermine. But most people only lose about 5 or 10% of the weight that they want to lose. So this is really not a great option. You'll notice that with Contrave, Casimia, Belviq, they all have the similar amount of weight loss. It's about 5 to 15%. Most of the folks that are coming to see us need to lose more like 25 to 50%, right, to really make a big impact on their health. And so, yes, we use these medications sometimes before surgery, sometimes after. As we learn more about these medications, they've been on the market about 3 to 4 years. We're knowing how to best utilize them for our patients. So the reality is E, all the above. So what's important for you to leave today knowing is that surgery is the most effective way to treat morbid obesity. This statement was made in 2004, which seems is a long time ago now. But there has been no treatment out there that is better than weight loss surgery to treat morbid obesity. Okay? But we should be trying it not as the first solution, but as something that if things don't work with regards to medical weight loss. They also recommended that you have it at a place that has the specialists to take care of your other medical diseases. And they recommended that you have all of your medical issues really worked out and optimized. We have folks that come in with diabetes that's uncontrolled. They want weight loss surgery. We say, we're going to work on your sugars first because it's unhealthy to have surgery when your sugars are so out of control. So we have to go to the diabetes clinic, get their sugars under control. We have folks that are in kidney failure or pre-kidney failure, and they need their kidneys worked on before they can have this. And so we just can't do, we aren't doing what we call Hail Mary passes to be able to do this surgery. You need to be prepared and well and stable for this surgery, because this is what people need to know. What's the risk of dying related to bariatric surgery? 1 in 1,000. I think people are kind of shocked by that number. They expect that number to be higher. Well, in the United States, you know how many bariatric programs there are? 776 across the United States. And every one of us puts their data in about dying related to bariatric surgery. And so this is a hard and fast number. There's over 200,000 bariatric surgeries done in the United States. So in 10 years, that's 2 million people. Okay? So there's about 10 million people that have put their data in, and so this is a very firm number. And I think that's really shocking to folks. I think people kind of hear, and there's a lot of myth and legends about, oh, well, you know, I knew this person in my church, and she didn't do very well with that surgery. I think she died. The reality is that it's very, very, very rare, okay? And the majority of those are going to be from one major thing, a blood clot. We've done 1,000 patients here, and we've had a death and pulmonary embolus, blood clot. It's one of the things that we work a lot on as a program to make sure that we are really doing a great job at. The reality is this happens in a certain group of people that already have had blood clots before and are probably on blood thinners. So if that's you, we'll talk a lot about this. But the reality is that if you don't lose weight, your blood clot issue is actually worse. So there is some risk involved associated with that. Is that number surprising to folks? Did they expect it to be higher? Yeah. Well, there's a lot of credit for a lot of folks that have worked really hard to get that number down, because in the 80s when we were doing open surgery, it was a lot higher. It was about 20 times higher. It was about 2 in 100. So we've gone from 2 in 100 to 1 in 1,000 over about the last 15 years. So that's what we call quality improvement, right? And you want to be the beneficiaries of that. All right. So who's at higher risk? If you've had bariatric surgery in the past and you want to be revised or changed, the scar tissue related to that previous surgery elevates your risk some. I did one today, so it's something that we do for some folks. If your BMI is above 60, okay, particularly if you're a man above 60, your risk is higher, about 4 times higher. And if you are severely deconditioned, if you're non-ambulatory, if you're not walking on your own, that's something that can put you at higher risk. So those are things we want to address beforehand. So how do I as a surgeon, how do I as the medical director of this program, how do I make sure that you are really low risk and you can go through without any problems? I wish I could promise that, but we do a really good job of doing that in general. Is that we do mostly first-time operations. We do very selected revisional surgeries. Those are case by case. If your BMI is above 60, we're probably going to work on getting you down lower before your surgery. And we can talk a little bit about that later. We're going to put you through a lot of tests. That means preoperative workup to make sure your sleep apnea is under control, your diabetes is under control, and so forth. We have a great operating room team. Our operating room is more like a ballet when we do this than anything else. It's wonderful. And then we're going to watch you very close. And we're going to educate you on what to look for. Okay, one of the things you'll find in our program that is very different is we spend a lot of time teaching you. We're teaching institutions. It's in our DNA. Probably have more handouts that you want to have. But the reality is we really feel like a lot of the information about how you can be successful is right in this book. We spend a lot of time putting this book together. And we've made it better over time. And we talk about how much is this a behavioral change and how much surgery helps you change your behavior. It's not the surgery that makes you successful. It's the behavior that you have that changes and how the surgery helps you do that behavioral change, right? So there's no magic to it. If you ask anybody who's had bariatric surgery in the past and say, I was successful, and they are successful, their weight has been controlled, they'll say, why? I follow the program. If you run into somebody who hasn't done as well, and ask them very honestly, they say, you know what, I was really good for a while, and then there were some things that happened, and life does happen. It does. Life does happen. And there are chances for people to do this a second time. But they'll be honest with you, they probably could have done a little bit more in their behavioral changes. And that's important that you hear that from me. Surgery is not a silver bullet. And there are folks that don't lose as much weight as they'd like. And that's a reality. So what's my goal as a surgeon? Well, I'm here to improve health. I'm here to add quality life years back that obesity is taking away. I want to increase your lifespan. If you have a good cosmetic result, good for you, okay? I've been fighting for about 15 years with insurance companies and people to have them understand this is not a cosmetic procedure. I'm not here to make people look better on the beach. It's not what we do, okay? I'm here to make sure, I want to see your list of medications go from 15 to 5. I want your medication list the sleep apnea machine to go away. I want those things to be what you achieve with regards to your overall health, not whether you can fit into a specific size outfit. But if that happens for you, congratulations, you worked hard. So who's a candidate for bariatric surgery? If your BMI is above 40, you're a candidate. If your BMI is of 35 or above and you have a significant health disease like sleep apnea or diabetes that is directly related to that, you can be a candidate as well. The thing that we really work on in our program is making sure that you know what you're getting into, that you understand what surgery you're having and what that surgery is going to do to your body, and that you understand what you're kind of buying into. And that means being compliant. So not missing your appointments and things like that. It's really important to let us know that your heart and your mind and your body are all going in the same direction. It's very common for folks to come in and say, I want to lose weight. And we said, well, what are you willing to do that? And they said, well, not very much. You know, we come to this appointment, no, can't do that. We come to the support group, that's not a good time for me. And you kind of get this feeling, well, how important is this to this person to have this change, right? And so your heart, we say your heart and your mind and your body all be going in the same direction for this surgery for you to get the most out of it, okay? So let's get to the surgeries. Everybody wants to know, hey, how do the surgeries work? There's a couple ways that the surgery works. We operate on the intestines in 2017 to change our weight. That could change over time. There's some other things that are being developed that are experimental, but right now we operate on the intestines. And what we want to do is we either want to make you absorb less of what you eat, or we want to restrict how much you can eat. And I'll show you that some of these surgeries combine these two effects together. So we're either going to eat less or absorb less. Talk about the band. This is a very rare operation these days. This was more common about 8 years ago. The band was something we implanted on top of the stomach that created kind of a restriction. This is something that we probably take more bands out than we actually put in. That's very honest of you to do. It worked very well for about 7 or 8 years. We find some folks develop scar tissue around the band, and then the band becomes rigid and it's hard to manage, and they can't get the right swallowing down. And so we sometimes have to take those out. But for 5 or 8 years, a lot of folks have had their weight either down or at least stabilized to where that had they not had the band at all, then they would be much worse off. So it's not that it's not perfect, it's just right for the right person. We typically today put these in female patients and typically younger patients. So when I mean younger, unfortunately, I mean about under the age of about 35. When your metabolism begins to slow, you need more than just kind of this to kind of lose weight. Okay, so we like it for the female population who may want to have children. We can deflate the band if they get pregnant, and it's kind of easier to manage if somebody's still growing in their family. When we talk about the band, the average result of the band is somebody typically loses about half of the extra weight. So I'm sorry, but I have to ask you to do a little bit of math with me just so you kind of get it, okay? I'll try to make the nice round numbers. So let's say you weigh 300 pounds, okay? And you're supposed to weigh, by the government little grid, says you're supposed to weigh 150 pounds. That means the extra weight that you carry is 150 pounds. Cool. All right, so you have 150 pounds extra, which means you're really, okay, that we need to deal with that. Now, when we talk about all these weight loss solutions, we talk about how much of the extra weight we lose. It's really important. All of the metrics, all the things we measure is about the extra weight we lose. So when we say somebody loses 50%, it's 50% of the extras, not 50% of the total, right? It's somebody who is 150 pounds overweight and they lose 50% of it, they're going to lose about. So if we take that 300-pound patient, they lose 75 pounds, they go from 300 to 225, right? That's a pretty significant weight loss, and that's an average. Now that means some people lose more and some people lose less, and where you're going to fit into is your specific. So is that person now skinny? No, they're not. They're healthier, but they're not skinny, right? And that's not our goal, right? We don't want that. We're not aiming for people to be thin. We're aiming for health. So that's the band. Our next thing we'll talk about, the good parts about the band, I should say, is it's adjustable and reversible. We can take it out. We can convert people to other things if they need weight loss surgery later. It's an outpatient procedure, so you come in and go home the same day, and that's attractive for some folks. And we obviously don't do any stapling or rearranging, as you're going to see with some of the other procedures. The downside to it is the weight loss is definitely slower. It's more intensive follow-up to always be in the right place to be able to swallow correctly, and probably a little less weight loss overall And if you're diabetic, it's probably not the best if you want your diabetes to be fully reversed. So those are the goods and the bads of the gastric band. Let's talk about the gastric bypass. It represents probably about half of the bariatric surgery done here, and that's pretty emblematic of what's going across the country. About half of the weight loss surgery is gastric bypass surgery. This is a little more complicated for people to understand, but in reality is that what we do is, this is the whole stomach. We take the top part of the stomach and we make a pouch. Pouch is holds about a large egg in size, so it's small. We connect the intestine up to it so that it drains, and the old stomach still makes acid and bile that comes and mixes down here. So this is called a bypass, a gastric bypass, because literally we are bypassing the old stomach. So I'll show you an animation of this that will probably make it a little more sense than me describing it in words. We do this laparoscopically, so it's small incisions like we do for gallbladder surgery. There's about 6 of them that we use to do everything we need to do. It's 2 surgeons operating. We have our instruments that go through these trocar sites, and so we're going to focus first on the stomach. We're going to create a pouch. Okay, that's going to be your new stomach. Okay, we take the top 10% of it and we turn that into the pouch. So it's actually cut away and stapled away from the old stomach. Okay, now we divide the small intestine. That small intestine is brought up because the food in the pouch needs to move into your body for absorption. So now we have a way for food to leave the pouch. Now, the stomach and the pancreas juices and the liver juices, the bile juices, all come from the stomach in the first part of the intestine, and that's all going to come back in together here. Okay? So we took a tube and made a Y out of it. And so now you know why we call it a Roux-en-Y gastric bypass. So the bile juices are in yellow, and the food juices are in blue, and they still mix together. And we bypass the stomach. Okay? Back to our graph. We talk about typically a gastric bypass patient losing about between 65 and 75% of the extra weight. So we start to see where that fits in. What are the good parts about the gastric bypass? The weight loss is pretty rapid. We have 15 years of experience in the U.S. with this. Probably 30 million people in the United States have had gastric bypasses in the last 15 to 20 years. It is an excellent cure for diabetes, so if sugar control is an issue for you, it's really important. And you also get some learning about what you're eating. If you don't eat the right things, so if you go get a malt and have a malt shake or milkshake, and you're going to get some pretty significant abdominal pain and diarrhea, which we call dumping and malabsorption. So you can remind yourself, oh yeah, I'm not supposed to have those things anymore, at least not that size, maybe a small little one. What are the downsides to it? I think people have some concerns about the rearrangement that goes along with this. They worry about the risk associated with it. It's definitely difficult to reverse. We do the surgery and we typically don't revise it. There's more vitamin supplementation with this than there are with other procedures. And nobody likes to have dumping and malabsorption, even though it's on both sides. So let's talk about an operation called the sleeve gastrectomy. This represents probably the other half, if you talk about 50% of surgery we do here and US-wide. And this one, we're actually going to remove a part of your stomach. Okay, we're going to take the stomach, which is kind of more like a woman's purse, and we're going to turn it into a tube. Okay, so we're going to remove about 2/3 of it. So your volume of your stomach should be a lot smaller. But it's more than just volume. We're going to remove a part of the stomach called the fundus, which is the top part that makes a hormone that is really important for hunger, called ghrelin. And it is made by the stomach, goes to the brain, and tells you whether you're full or not. And by removing that part of the stomach, we really help with satiety and feeling of fullness, even when we're not eating a lot. So here's an animation of what a sleeve gastrectomy looks like. I tell folks that our stomach was designed for when we were out in the Serengeti chasing down wildebeest, because we had to have a huge stomach to be able to eat enough food so that if we didn't eat for 3 days, that there was enough calories in that one meal that we caught that we would make it to the next meal, right? That's what it means to survive. Do we live like that anymore? Right? We actually have 4 meals a day, right? Taco Bell gave us a 4th meal just because if we were late at night, because that hunger that hits us at night, right? Instead of going to sleep like we should, get better sleep, we get up and we go get ourselves another meal. So here's the stomach. Our stomach holds about 1 liter to 1.5 liters of food. It's designed for us to gorge, okay? But we do that for Thanksgiving, right? Have the biggest meal of the year. And then 2 hours later, what do? Go in and make another sandwich, start eating around the sides, right? Because the food is out of our stomach in 2 to 3 hours, no matter how big a meal you have. No matter how many calories you consume, your stomach is empty in about 3 hours, right? So here we make a much smaller stomach, okay? And the other part of the stomach, it's gone. It's removed and sent to pathology. So it's not coming back. There can be some stretching of this, like there can be some stretching of the pouch, but actually we don't see a lot of that, and we don't see the weight regain really related to that. So that's a fairly controversial topic that we can talk about more at another time. So that's the sleeve gastrectomy. Those are the 3 operations that we do here at UT. It represents 99% of all types of surgery done in the United States. What are the good parts about the sleeve? Is the weight loss is close to bypass, maybe not as much. There aren't any adjustments like a band. The recovery is people are in the hospital between 1 and 2 days, and the durability is now proving itself to be pretty sturdy. What are the downsides of the sleeve gastrectomy? As I described, that part of the stomach's not coming back. I can't put it back in. And that staple line that we do is the longest staple line in surgery, so there's a chance for a leak of that. And that's something we work very diligently to try to minimize. So one more last graph, I promise, is where does the weight loss fit? Well, somewhere between 50 and 65%. So if you're looking at the total amount of weight loss, band's the lowest, sleeve, bypass, okay, with regards to how much weight loss folks have. This chart is the chart that, for me, convinced me that I should be dedicating my life to bariatric surgery, and that these are the 4 most common health diseases that Americans have: diabetes, hypertension, sleep apnea, and cholesterol. How much money do we spend, and do insurance companies spend, and do the federal government spend treating you with medications for these or machines for these, right? Does our diabetes ever go away with insulin or metformin? No, it doesn't. Does the high blood pressure go away when we take our blood pressure medicine? No. Controls it. What if we stop taking it? Blood pressure goes back up. What about our sleep apnea? Does it get better when we put the CPAP machine on? Well, our symptoms get better, but our sleep apnea doesn't go away. And how about our cholesterol? If we stop taking our cholesterol medicine, our cholesterol goes back up. Well, in bariatric surgery, particularly in gastric bypass surgery, when we operate on patients, 80% of patients have their diabetes go away. Right? That means not on medication and their sugar's in the normal range. Right? That's better than medicine, right? Not only just one, hypertension better in about 60% of patients. Sleep apnea gone in about 8 out of 10, and cholesterol problems gone in about 9 out of 10. So the impact that I can have on my community health is huge in helping folks treat obesity. Okay? No medicine, there won't be another medicine out that will do this. And so that's how effective surgery can be. This is a graph that shows 2 groups of people. And it's unfortunately people that, these graphs are the number of people that died. This had 6% deaths in it, which 6 out of 100. This had 0.6. So there's 10 times more people that died in this group than that did. These are the people that did not do bariatric surgery, okay? This is the people that had bariatric surgery. I cannot tell you that bariatric surgery does not have risks. I just told you it did have risks. But what I'm showing you here is that the risks are 10 times higher to not do anything about it. Now, I'm not saying surgery is what you need to do, but not addressing your weight will catch you. And so when you decide to do that is up to you, but it's a fact that is inescapable. So when we do bariatric surgery for folks, people live longer. And that's what we want to do. So hopefully today I'll be able to show you a feeling for what our program is like. Here's some of the issues we want you to help work on. Is we want this to be the right time for you. And the way that we know it's the right time for you is you're making your appointments and you're doing some of those changes you need to do. If you're gaining weight while you're in our program, it kind of tells us probably your head, heart, and mind aren't all in the same direction. Some of the folks I'll finish with, this is a gentleman who came to me with BMI of 70. He's going to go on disability. Couldn't go to work. His joints were too bad. This is his picture actually after about 9 months. This is his 9 months of medical weight loss. He lost about 100 pounds to be a candidate for bariatric surgery. He got to about a BMI of 58. I went and operated on him. Did a gastric bypass surgery for him. This is back in 2007 now. Here's him at 3 months. This is him at 6 months, and this is him at 2 years. People say, well, didn't it look great? Look at those pants that he is able to give away. But I look at it and say, this guy is putting food on his table and is full-time employed and working instead of being disabled, right? I've been able to do hernia surgeries for him and lots of other things to get him, keep him healthy. So a great story for us. An individual that had a band. This is her and her flamingo in her office. And unless you saw those two things, you might not think that those are the same folks. So she lost 2 pounds every month for 2 years. It was a very steady, slow weight loss for her. She's had some difficulties with some weight regain, but she has not returned to her previous weight. She believes so much in the band that her husband got a band, so they have matching bands. That's actually something we preach, if we can say that, preach, is that we do a lot of families. We do husband, wives, we do father-daughter, do mother-daughter, mother-daughter, sister. We've done all variations because when folks come, people see how lives change. And we have a lot of families who the support person is their support person, and a lot of times the support person comes and says, well, that's not for me, and then they see their loved one going through and having success, and they go, wow, I can't miss out on this, right? There's no way they're going to be healthy, and I'm not going to be healthy. So we do a lot of families, and we tend to have family members do the same operation, okay? Because these operations are very different from each other. They have very different lifestyles. They have very different eating patterns. So a lot of times we have folks do the same operation with the person they spend the most time with, so that they have similar experiences, because you're still going to eat, right? We still need to be human, right? We still need to have those shared human moments at holiday times when we're together as families, right? And so it's important that you can share that experience. So you'll find us trying to recommend, if you are doing it with someone, to think about similar operations so that you can have similar lifestyles. One of our patients did a sleeve. Obviously, she's pretty psyched. She was happy before. Look at her. She wasn't unhappy, right? But she definitely is happier with her weight loss over time. You know, as I said before, no silver bullet with surgery. I'm a surgeon. I wish I could say every single patient I do gets to perfect weight. That's not the reality. It's a tool. It's why we educate a lot, because this education helps you use your tool correctly, right? And so if you use your tool correctly, you have the highest chance of having the best outcome. There's going to be a time in which it's easy to lose weight. And maybe you don't have to be perfect in how you live. But we want to teach you that that's the time when you kind of have to really change your behavior. And the honeymoon period doesn't last forever, okay? So we want to prepare you for the times that it's not easy. Here's how you get through our program. You can go find programs that are easier to get through. You can go find programs that ask you to do less, okay? We've been doing this program for 10 years, so we've made it better each year that we've done it, and our results really speak for themselves. So this seminar is one of the requirements that you got to do, and you can see how much information you've gotten hopefully tonight. We're going to have you come to our educational visits and get ready for your surgery, your pre-op class, dietitian's visits, support group. So we do try to do support groups so that folks can be plugged in. Not everybody has a family member that's had it. They need to know, and so we have a support group's a great place to go meet people and find out how did it work for you. What were the goods? What were the bads? Why'd you choose that surgery? And you'll get 10 different people telling you their thoughts in a short period of time, whereas you sit and wait for me, you get one person telling you their thoughts. So there'll be time for us to meet in the office and talk about things as well. And of course, lots of materials.